Hello, my name is Stan Rockson from Stanford University. I'm here to speak briefly about the diagnosis of lymphedema and lipedema. So we'll start with the topic of lymphedema. Lymphedema is generally divided into two broad categories. The primary form is the one that is based on heritable conditions, does not need to be present at birth, but often is. The secondary form is thought to occur in a lymphatic circulation that was previously normal and becomes damaged. In the Western world, we know that this is predominated by cancer therapeutics, and a variety of cancers can, based upon lymph node excision and radiation therapy, ultimately lead to lymphedema of one or more of the extremities or other parts of the body. Other causes of secondary lymphedema include trauma, surgical or idiopathic, as well as infection. Venous disease can be another cause of secondary lymphedema based upon increases in lymphatic preload. Primary lymphedema is the much less common cause. In the United States, only about 45,000 individuals have this particular condition, as opposed to perhaps 5 million who have the secondary form. We divide primary lymphedema into three broad categories. The congenital form represents about 25% of the total and is present at birth or appears within several weeks after birth. What used to be called lymphedema precox occurs at puberty or young adulthood and represents perhaps 60 to 80% of the total number of patients with primary lymphedema. And lymphedema tarda, poorly understood, occurs after the age of 35 and represents 10% or less of those with primary lymphedema. We have a staging system for lymphedema which progresses from stage 0 to stage 3. In stage 0, there is no detectable edema, but there is imaging or other physiological evidence that edema accumulation is occurring in the limb, and this is felt to be a preclinical stage of lymphedema. In stage 1, the edema subsides with elevation of the limb. In stage 2, elevation will not completely reduce the degree of swelling, although pitting remains present. And later in stage 2, we begin to see the skin changes of lymphedema, which become predominant in stage 3. So there are a variety of skin changes and changes in the tissues that can occur. Of course, there's a lot of cutaneous inflammation. There is also thickening of the skin. We see prominent pitting, which can disappear over time, as we saw from the staging classification. There is lichenification of the skin, thickening, and overgrowth of the epidermal components. We also see evidence of nodular changes when this overgrowth of the skin becomes more predominant, and eventually this can take a very extreme form. We can see so-called lymph cysts, which are actually little bits of the lymphatic vasculature that bubble up to the surface. These are fluid-filled. Because the lymphatics themselves are filled with fluid, they can rupture and leak fluid, which we call lymphoria, and can be sources of infection as well. The diagnosis of lymphedema is predominantly based upon the physical examination and the search for these physical findings, but if there is any doubt, we turn to various imaging modalities. The so-called gold standard for lymphedema is radionuclide lymphoscintigraphy, which involves the injection of a radio-labeled large molecule. In the United States, we use technetium-labeled sulfur colloid, but albumin can also be employed. And we are looking for two findings. One is the delayed appearance of the material within the draining lymph nodes after injection distally into the subdermal space. And the second is accumulation of the radiolabel in the transit path between the injection site and the draining lymph nodes, which we call dermal backflow. A more sophisticated and newer technique, which unfortunately is not quantifiable, is near-infrared fluorescent imaging, which relies upon a very similar mode of introduction of the material, which fluoresces under near-infrared light. And again, we are looking for dermal backflow and various patterns of dermal backflow as the primary finding that would relate to the presence of lymphedema. We also can utilize magnetic resonance imaging, and this is called MR lymphangiography, where we can actually use heavily T2-weighted imaging to directly see the lymphatic vessels. Direct contrast lymphography is not very commonly performed anymore, but is certainly useful when it is employed for pre-surgical planning or to understand if there is an interventional approach to alleviate the lymphedema presentation. A diagnosis discussion of lymphedema should not ignore the necessary interventions to look at the venous circulation as well. The interdependence of the venous and the lymphatic vasculature is profound, and when there is any cause of net venous hypertension, this will lead to an increase in the afterload it will lead to an increase in the preload on the lymphatic vasculature and can overwhelm it, leading to a clinical presentation with lymphedema. So every effort should be made in the appropriate settings to look for correctable causes of venous hypertension. These would include in the lower extremity May-Turner syndrome or iliac vein occlusion syndrome, and also various forms of reflux, which can be interrogated through standard ultrasonographic techniques. For stage 0 lymphedema, we rely on a variety of measures to look for non-clinical evidence of edema accumulation. The most commonly employed in the United States today is so-called bioimpedance spectroscopy. This is not specific for lymphatic edema, but will detect any form of preclinical edema in a limb. Now, in the setting where lymphedema is of concern, for example, in a cancer survivor, the finding of abnormal bioimpedance would dictate that stage 0 lymphedema might be present. Moving on to lipedema. Lipedema can be confused with lymphedema. It typically involves exclusively the lower extremities, but will involve them symmetrically so that we do not see unilateral edema of a lower extremity. It does occur in the upper extremities, but this is quite unusual. Lipedema has several distinct attributes. Number one is that it is seen virtually exclusively in women, so this does not need to be a consideration except under rare circumstances in men. It can be familially distributed, and about 50% of the patients who carry the diagnosis of lipedema have a family history of other affected female family members. It is associated quite often with discomfort. This is a primary attribute of lipedema, which is less commonly seen in lymphedema, where again, pain is present, but the discomfort that is described is relatively mild, whereas in lipedema, the discomfort is a predominant attribute. There are a variety of issues that would help to discriminate lipedema from lymphedema. First is the character of the tissue itself. In lymphedema, when thickening of the limbs occur that might be confused with lipedema, the tissue will be firm, whereas in lipedema, the tissue is soft, and in the latter stages of lipedema, one can also detect the nodular quality of the fatty overgrowth that characterizes lipedema, which will not be present in lymphedema. We also know that the edema, when present in lipedema, is non-pitting, whereas in the earlier stages of lymphedema, of course, it will be pitting, and that pitting quality will be retained until relatively late in the course. Lymphedema can involve only a single limb, whereas lipedema, as we've said, is going to be quite symmetric, and a characteristic attribute of lipedema, which can be seen but not necessarily seen in lymphedema, is sparing of the feet. So in lipedema, the edema begins at the ankle and progresses upward. In lymphedema, the foot may be involved but not necessarily. And all of these can, of course, be confused with lifestyle-induced obesity, which share attributes with lipedema, but also will involve the central trunk as well as the extremities themselves. There are 4 stages of lipedema. In stage 1, there is an even skin surface with an enlarged hypodermis. In stage 2, The skin pattern becomes uneven with development of nodular or mass-like subcutaneous fat. One can feel lipomas and or angiolipomas. In stage 3, there are large growths of nodular fat, and this severely changes the contour of the thighs and around the knee, leading to tremendous deformity of the limb itself. And in stage 4, we see the advent of secondary lymphedema as a byproduct of the pre-existing lipedema. When we talk about diagnosis of lipedema, we have to emphasize that this is purely a clinical diagnosis. There are no characteristic imaging attributes for lipedema. There are no identified biomarkers, and histopathology is not helpful. Consequently, it is purely a clinical diagnosis, but it's important to recognize that confusion with constitutional adiposity is certainly easy to occur in this particular condition.